looks like this may like to slide down. If it keeps sliding, feel free to, muscle it up. I want to welcome everyone to this morning's event, particularly those, everyone, whether you're in the room or you're visiting and viewing in online on YouTube or Facebook. Welcome to Moving Forward. This is World Mental Health Day. October 10th is World Mental Health Day, so it's being acknowledged in several ways in our community. This is our effort today to recognize that and get some terrific awareness and training and conversation for us today. So thank you for joining us again, whether you're live or virtually. I want to introduce a couple things and welcome everyone, and then introduce our first speaker. Here's the morning agenda, the morning schedule. Professor Amy is going to speak at 9 and speak about 45, 50 minutes. Then we'll take a 10 or so minute break, and then Todd Crush will speak our second hour, same amount of time. We'll take another break, and then we'll have our third hour be a Q&A presentation for them. Speaking of Q&A, if you got a bag on your way in the door, if you didn't, these are on the tables in the back. But what we would like for you to do, and this is in person, sorry, live streamers, but for those of you in person, we would like for you to write down the questions that you have as they come to you this morning, as you're listening to the two presentations, and you'll turn these cards in to me, and I'll facilitate the conversation. That helps us keep things flowing, and also for audio purposes, it's a little easier. So be thinking about that. Put as many questions as you want on there. We'll get through as many as we can during that last hour for this morning. I didn't introduce myself. Hi, I'm John Gregory with Samaritan Counseling Services of the Gulf Coast. This is one of the kinds of events we like to put on occasionally, and it's not our people putting on the presentations. We bring outsiders in to help us expand knowledge and awareness, and so we're very thrilled to have our two presenters today to do that for us. I do want to mention, and you'll hear this repeated this morning, just sort of a trigger warning for you. The content you hear this morning, excuse me, will include references to things that may be a trigger for you. So feel free to, if you need to leave the room or step away from your device that you're watching through. Suicidal ideation will be mentioned, abuse, schizophrenic symptoms, near-death experiences, those kinds of things. So just want to acknowledge that and make sure that you're taking care of yourself as you need this morning. For those of you mental health professionals in the room who or online who are looking for the CEUs from this morning, for those of you present, there are forms out on the registration table that we need you to complete before you leave today. So make sure you get those. If you didn't get one and fill those out and leave that either on the table or with one of our staff. With Samaritan, we got 4 here and 2 ladies at the table already. So leave that with us, and we will submit those for you. You don't need to do anything but turn in the form. For those of you who are streaming, if you would like to also submit for that, you will need to just send me an email. And here's my email address, so I'll put it on the screen for you. It's john@samaritangulfcoast.com. Just send me an email, and I will send you a link to an online form that you can complete for that. And we want to make sure to give you the credit for those things. I think that's all I had to say, except I will say in your bag also is just a quick program reminder of the morning. And on the back, if you didn't get a bag, I'm looking like, where's the bag? It's at the table. We'll get you a bag. Okay, I'll make sure you can get one to you. There's a list of our exhibitors that are back in the back of the ballroom. So you just want to take time to, if you haven't already, take time to get to meet them during our break times and learn more about them. Harmony Harbor also sponsored the event this morning, so thank you, Harmony Harbor. And then we have representatives here from Centerstone and Dr. Greeter's psychiatry office, so thank you very much. And our two presenters also have tables in the back, so as they reference their resources and their books, I would encourage you to stop back there during our break time and look at those as well. So let me go ahead and make sure I give them all the time that we've promised them. And I want to introduce our first speaker and welcome her to the stage. Amy Weissman DiMamani is a professor at the University of Miami. Is also a licensed clinical psychologist. She earned her doctorate at the University of Southern California and completed her clinical internship at UCLA. That's interesting. Both of those, like across the street almost from each other. Her research is focused on family and cultural factors that influence the course and outcome of serious mental illness. She's published over 100 manuscripts in areas related to mental illness, and I just noticed back on her table, like freshly produced book that I'm sure you'll reference this morning. So we're so glad that you could drive over and be with us this morning. Please welcome Amy Weissman-DiMimonte to the stage.
Good morning. I am thrilled to be here. Thank you for that lovely introduction, John. As John mentioned, I'm a clinical psychologist by training, and I've spent the better part of my career studying family and psychosocial factors that influence the course of schizophrenia and related serious mental illness, and building treatment interventions based on some of these findings to try to help people with these illnesses and their families manage the course and live fuller, more connected lives. Before I delve in, I want to say a few words about how I came to be here today. A couple of months ago, I got an email from John asking if I'd be willing to come and talk about my research in schizophrenia and about my intervention, something I'm always happy to do. And then he mentioned that I would be speaking alongside Todd Arkyn Crush, the author of this amazing book from it today. And I ordered the book, and I think it's accurate to say I devoured the book in probably a day and change. And Todd will, in his own words, tell you his story. I imagine he will speak about the book in his own words. But I said to him when we met, you know, Todd, you could really be the spokesperson for my culturally informed therapy. The way he has navigated his illness is so inspirational, and I feel honored to share the stage with him today. I will briefly reference some of Todd's writings in my talk, things that he's talked about himself, but I won't steal his thunder. He will talk about his own lived experience in his own words, but I hope that you can see how my research perspectives and that I've learned through my clinical work and research and that of others and my views align with Todd's lived experience in managing this this illness that can be, you know, very challenging. And I think this synergy is, we need more of this to work alongside people with lived experience to improve our interventions and vice versa. So again, I am so honored to thank you, John, for coordinating, and thank you, Todd, for sharing the stage with me today. Let me give you a quick roadmap about what I'm going to talk about. So I will give a very brief overview of schizophrenia and its causes. I will talk about research that really informed the development of the culturally informed therapy that I'm going to present on today, and I'll talk a little bit about some of our findings. And hopefully, if there's time, I can talk about how we're taking this research and some of our future directions. So I imagine that most people in the audience and on the live stream are in some way acquainted with serious mental illness. Either you're practitioners or you are family members of someone, or you have a serious mental illness. So I won't go in depth about what the disorder is and the causes, but it is considered to be one of the most severe forms of mental illness. It impacts many domains, one's thought processes, one's mood, and functioning. And you know, you can try to imagine trying to follow a conversation where words feel scrambled or disconnected, and understanding tone or intent like sarcasm or metaphor feels like a struggle, and a person's mood can be unpredictable or numb. Even everyday tasks, sometimes like getting dressed, managing time, and navigating things like public transportation can be overwhelming. And something I want to mention now is that because the behaviors when somebody is in the midst of a psychotic episode can appear unusual and scary to someone who isn't familiar with them, there is a widespread myth that people with serious mental illness are dangerous. In reality, this perception is gravely overestimated. Individuals with serious mental illness are far, far more likely to be the victims of violence than the perpetrators. And unfortunately, this perception carries into things like law enforcement and can sometimes lead to unnecessary violent interactions between police officers and people with serious mental illness. And I hope to revisit that at the end of my talk. So I want to say that this disorder has a complex relationship with biological and environmental causes. It is a highly heritable disorder. This just means that genes play a major role in determining who may get the disorder. It's no guarantee if you have a close relative that has it, you will get it, but your likelihood is much higher, and there's neurochemical changes that we see in dopamine and glutamate systems that these don't seem to function similarly in people with this disorder, and this is often associated with excess levels of dopamine and the like with excess symptoms. And there are some prenatal influences as well, complications during pregnancy, infections, and things like that are thought to be more, they make it more likely that a person that has a genetic risk will experience the disorder, but they don't cause the disorder per se. And although schizophrenia is a genetic disorder, environmental factors like early life trauma, abuse, and neglect, Todd is going to share his story and how these factors influenced his life. These environmental factors, including discrimination, poverty, and isolation, arguably carry more weight in how these disorders progress than do the biological factors. Even something as basic as taking one's medication consistently depends on a person's surrounding and their support system. Other environmentally related things that won't cause the disorder but account for a much poorer course are also the use of substances. They're not good for anyone, but they're exponentially worse for somebody who's already compromised and having symptoms. Schizophrenia, the prevalence rates of the disorder, it affects about 1 in 100 people worldwide, and that is a fairly robust estimate. It hasn't changed very much over the years, and it looks pretty uniform around the world, while we do see some blips and pockets of places with higher and lower. Black people in the United States have a worse prognosis than their white counterparts. Something that is very interesting is that only is in countries where they are the minority in numbers, so that is not the case in Africa. It's the case in the United States and England and other places, so that's telling, and maybe that's something we can talk about more in the Q&A. I'm not going to focus on that line of research today, although I've done some. I'm going to focus on other minoritized groups in the United States and in the world that actually, in many ways, this sounds counterintuitive, but they actually have a more benign course, a better course of mental illness, despite usually developing countries usually have lower SES and minoritized groups. I'm going to focus on, because this is where my research has taken me, mostly on people from Spanish-speaking countries in the United States. We see a Hispanic paradox in that they are economically lower SES, less likely to have insurance, yet they live longer and they have lower prevalence of most mental disorders than their non-Hispanic white counterparts. So I'm going to talk about that because trying to understand that has really been the basis of my career. I became fascinated with early findings by the World Health Organization that these large institutions really had, they conducted a series of studies using standardized assessment procedures in numerous countries around the world, where they were also incorporating locals to make sure they were getting the nuances of the language right, and the same protocol. And they found in multiple waves of studies in the early 70s, in the late 70s, again in the 90s, that people with schizophrenia and other psychotic spectrum disorders who reside in industrialized countries, the United States, England, and Canada, had a less favorable course, not the prevalence rates are pretty similar, but a less favorable course than their counterparts who reside in more developing countries. I'm usually going to use the word traditional rather than developing, because developing is really getting at income, and I'm focused more on variables. When I say traditional cultures, I mean cultures that tend to put group goals over individual goals, that tend to have clearer codes for behaving, and so I will be kind of defining what I mean and why I think that people from those cultures may fare better when they have a serious mental illness. And so these are some of the variables. They look yellow or orange on my screen in the middle that I am going to zero in on, that I have examined in my own research to help me understand why we might see these cultural differences and how can we try to isolate what the ingredients are that account for that so we can build them into better interventions. So I'm going to start by talking about the emotional climate of a household and its relationship to the prognosis of the illness. One of the most widely measured psychosocial constructs in psychiatry and psychology is this very simple rating of the emotional climate. It's called expressed emotion, or more affectionately for those of us who study it, EE. And it's a measure of the amount of criticism and hostility mainly, and there is another component, emotional over-involvement, which is when a parent is overly intrusive or overly self-sacrificing as well. People with schizophrenia and now a host of other disorders who this early research in this graph is from a meta-analysis of people with schizophrenia. A meta-analysis just means that there was multiple studies from around the world showing that for patients who have an index episode, that means the first time they were hospitalized with a psychiatric illness, who recognized measures called either the Camberwell Family Interview or a shorter version of that, the 5-minute speech sample, which has excellent concordance. If one says the person's high EE, so does the other. Those folks that were released to the hospital to live with high EE, to live in high EE households, are twice as likely to relapse within a 9-month period compared to those who return to live in warm, empathic environments. That's not rocket science. Nobody functions well in critical and hostile environments, but for people who are already compromised, it really is, it's not conducive to managing an already very challenging illness. And these findings have now been extended to, related disorders like bipolar and depression, but also things like conduct disorder in children, eating disorders, and so it's a finding that really relates to managing any adversity. People don't do as well when they're not in environments that are supportive. So I was very interested in that finding in my early work about why do people from about the WHO findings, why people from more traditional cultures have a more benign or better course of illness. And I wondered if the expressed emotion construct, because we see this Hispanic paradox in the US, would that tell us something? Could there be higher base rates of high expressed emotion in our non-Hispanic white families compared to our Hispanic? And I want to say this very briefly, but in my slides you'll see me use sometimes Hispanic, sometimes a variation of Latino, Latine, or Latina, and that is because in in the East Coast of our country, Puerto Ricans and Cubans tend to prefer the designation Hispanic. I could spend an hour talking about that alone. On the West Coast, some version of Latine is often preferred, and so it depends on who I'm examining at the moment, and also over the years the language changes, so that's why there might be some discrepancies in my slides. But back to this study, I wanted to see if we might see higher rates of high EE in our non-Hispanic white family members. Could that tell us something? And so I had funding from the NIH at the time, and I took my research team, which is usually whichever graduate students are in my lab, so I should give a shout out to them because I couldn't do any of my research without them. But we went to 3 cities, Boston, Miami, and Los Angeles, and we interviewed white and Hispanic family members using these measures, the gold standard measures that I mentioned a minute ago, the Camberwell family interview and the 5-minute speech sample. And we found, lo and behold, that our non-Hispanic white participants were 3 to 5 times more likely to be rated as high in expressed emotion than our Hispanic families. I say 3 to 5 because it depended on which measure we were using. And I'm going to link that back up to culture in a minute. Why might that be? But in 2 other studies, we found that the attributions, and when I say attributions, I'm referring to the causal beliefs that family members have about why their loved one is ill, and their views on how much the person could control the symptoms of the illness and the onset. And we found that high expressed emotion relatives were more likely to see the cause and mainly the maintenance of the disorder as the patient's fault to some degree, meaning that it's something that they should and could do a better job managing, and sometimes even the onset, more so the management of it. And this was a culture general finding. It was true for whites, it was true for our Latino clients, and the overarching model supports basic findings in social psychology. If we perceive an action or an event for an adverse event of another person as something that they brought on to themselves or didn't help themselves control it, we're likely to be angry, frustrated, not so willing to help. If we see it as something that's out of their control, we're much more forgiving. And I would like to use an example of from Todd's life, from Beneath the Ice. He talks about going into the wilderness for years on end. If his loved ones see, Todd, I'm talking about you, if his loved ones see this as, because Todd was so unwell, he didn't have any other way of managing that, they're likely to make uncontrollable attributions, and they're likely to respond with warmth and empathy and a desire to help Todd financially or emotionally. Yet if they make an attribution that this was somehow a choice to shun work-related activities or childcare or whatever, the emotional responses to the exact same event could be anger, frustration, and as in turn, less of a desire to support Todd in whatever way. And so, again, this is basic social psychology. Most of it is very intuitive. But I wanted to see, could we see base rates differences in the attributions that people from these traditional cultures that have a more benign course make towards their family members? And so in this study, it was an analog study. It's the only study that was not with actual family members, and we did that because we wanted experimental control over what the participants saw. So for this study that I'm going to talk about right now, we created vignettes of a fictional person named Victor who was described to meet the diagnostic and statistical manual criteria for schizophrenia. They were asked to imagine that this person was their brother, Victor, and we conducted the study in the US and Mexico, so the measures and everything was translated and back translated into Spanish, so participants were seeing the same description but in their own language. And we used college students who were psychology majors in a expensive private institution in the U.S., University of Southern California, and a comparable university called ITESO in Guadalajara, Mexico, also psychology students, so comparable ages, comparable areas of studies. And we asked participants to read this vignette and then to tell us if this were your brother, how are you likely to see the illness? How much control does Victor have over managing? And we asked, breaking down the types of symptoms, and they rated those. How much frustration and anger and a series of negatively balanced emotions do you think you'd feel towards your sibling, and the flip side, all of these positive emotions? And in turn, how willing do you think you would be to help your brother? Well, we found support for Bernie Weiner's model completely across the board for both sets of participants. Again, that's a known factor. If we make negative attributions that are controllable, then we're more likely to feel frustrated and angry and not likely to help. What was new and what was striking is that we found that our non-Hispanic white participants made more controllable attributions towards the symptoms and expressed more intense unfavorable and less intense favorable emotions and less willingness to help their hypothetical symptoms. So this gives us some support for why we might see these differences that the World Health Organization has found in multiple highly controlled studies. And it also so it gives us some insights into what we might want to work with families and patients on in intervention programs. I do want to take a moment to say, why would we see this? And so I want to spend a minute saying, if you think really about the United States and some of the prevailing philosophies, even from our forefathers, there is this notion that with hard work, one can rise from rags to riches. You can overcome anything. It's the American dream. That philosophy is amazing, and people can accomplish all sorts of really difficult feats when they have that philosophy. Todd is our example. So it can be great. When it breaks down is when it is applied to other people in circumstances that might really be beyond their control. To some degree, schizophrenia is a disorder that you can manage beautifully and you can live a productive life. But there are some points in this disorder that the patient is neurochemically imbalanced and they can't do the things that maybe they could do before and will do again. And so that's when it breaks down. I think it's important to mention in our scales, our white families don't love their relatives or care any less about them. They just have a different set of attributions that is really adaptive in some settings and not so much in others. So I think that's important to point out. The next area I'm going to talk about is religiosity and spirituality. When I was doing some of my early research, driving around Los Angeles and interviewing family members, I kept hearing references to their faith as a coping mechanism. And we do know that people from traditional cultures tend to not only be more religious than their white counterparts, but they tend to integrate their faith more into their day-to-day lives. I have a quote on the screen about that I think captures the essence of many of these comments. They're using their faith to manage something that's really, really difficult. And so then I started to wonder, could that be another factor, that there's this whole meaning framework? There's also a support system that comes with religious institutions. There's notions that we know from secular versions of psychology, forgiveness and empathy. All those are associated with better mental health. And so I started pouring through the literature, and in that time, in the early 90s, even on covers of like Newsweek and Time, there was all this research cropping up about how religious people tend to be healthier, happier. My colleague, Mike McCullough, a few years ago did a meta-analysis looking at all-cause mortality, death for any reason, and guess what? Religious people live longer than their non-religious counterparts. And so we wondered about taking the components, both secularly, the ingredients of what is it about religion that helps people live better lives and to avoid some behavioral triggers. They're less likely to abuse drugs and alcohol and things like that, and work them into our treatment program. The last area I'm going to talk about is family cohesion. As I said, our white families, especially those that are coming into treatment, they love their family members. We do see, and actually there's no differences in how the two groups score on their measure of family cohesion. I'll talk about that a bit more. We did find, and again, I think this is intuitive, we found that for people with schizophrenia and their family members, if they view their family as more cohesive, more supportive, more loving, the people with the illness not only have less severe psychiatric symptoms, both them and their family members have less depression, less anxiety, less stress. And so really building that into our treatment programs, but also trying to capture a little bit of the collectivistic flavor of the more extended family networks, the seeing the person as an extension of themselves. It sounds like it goes against the grain of psychology where we try to foster independence, but that may have a lot of merit here. And so we took research from our own findings and from our colleagues' findings, and we built this intervention. I published the treatment manual for this in 2021, and it's a 5-segmented intervention. I'm going to talk very briefly about each of the components. The first one, family collectivism, is aimed at really trying to fortify family members, so not the person with the illness. This is the target is the family themselves. And there's a lot of ways that we do this. One is right off the bat, the fact that the family members are in the room shows that even if they don't see eye to eye on anything else, they're committed to the family because they're coming here. And so we talk a lot about what they're hoping to gain, and usually it's another guaranteed opportunity to show some commonalities, because they're almost always there because they want so-and-so to get better, or they want their family to function better. And so right there, your important goals are similar. You might not be in agreement on how to get there. We talk about what the concept of family means and try to get them to come up with some, agree on some characteristics that they all want to strive for in their ideal family, their own family and their ideal family. We have homework for every session of this because we want it to be integrated into their day-to-day lives. So we ask them to explore their families, exploring their traditions and their the things that they like to do together, and encouraging them to actually set aside time to do things that are connecting, because that's what we think is some of what counts for the better course of illness in traditional cultures. And it's not just that they love their families, they have each other's backs, they're spending time together, they're prepping meals. So we're encouraging it doesn't matter what their family background was. We do this for our white families and our the clients that already tend to do that as well. And then in the second module of the intervention, we spend a lot of time talking about the psychoeducation of managing schizophrenia. So helping the family understand the biology of it, getting a clear sense of their culture's view of the disorder, and this can help with dispelling any stigmas that they may have around it, or how it may be viewed as something that makes them feel like they're damaged rather than just simply ill, like if you are a person with diabetes or cancer. So we spend a lot of time on that. We spend a lot of time talking about the symptoms, usually what we call the positive symptoms, and there is nothing positive about these symptoms. The behaviors that are the hallmarks of this disorder, like having hallucinations, so perceptual experiences that others wouldn't have, and the delusions, having beliefs that most others in your community wouldn't believe. Those things the family usually recognize as symptoms because they're unusual. It's really the negative symptoms, those that occur below a baseline. The person has very restricted range of emotion, or they don't want to shower. Those are the things that are more likely to be targeted in those high EE comments, because they think that those are things that are personality and that the patient can and should do better. And so those are the things that often need more attention. So we spend a lot of time on that. We also spend a lot of time on depression and anxiety, because if you're managing this disorder, it's challenging, and so the people with the illness themselves often have high levels of comorbid depression and anxiety, as do the family members, and this is helpful for using the true and tried cognitive behavioral ways. These symptoms respond very well to intervention, and it's also helpful for shifting the blame and the focus of therapy away from just the person managing the serious mental illness. It's an opportunity to really work to improve the lives of the family members. We talk about the genetic background. I mentioned this a little already to help them understand it in the way you might understand a predisposition to diabetes, to take the stigma away. And then we talk about the comorbidity with substance abuse, which unfortunately, because it's a burden to have this disorder, and people with it often self-medicate, and unfortunately, psychosocial cognitive behavioral interventions, which ours is, don't respond very well if a person is also using drugs, so we hit that really hard when we need to. And we talk about how the family can help. I'm speaking a little bit rapidly now because I think I'm running close on time, but the third module we developed is spiritual coping, where we really try to help our families tap into religious or existential, if they're not religious, beliefs. So we talk a lot about their participation in, or their desire for participation in religious communities. We talk about support system they have. It could be other types of community settings that aren't religious but have the feel of a community. You probably wonder, what do you do if a client or a family comes in and they're not religious? And we never make any attempts to steer people towards a religious point of view. We just focus on philosophical beliefs about right and wrong. We have parallel handouts for people who are not interested in a religious intervention. They might, instead of praying, they might meditate or go to yoga or walk in nature to be connected with the universe. So it's that we're getting at the same, we hope, same things. And so we're trying to foster more positive attitudes of forgiveness, gratitude, generosity. All of these things are associated with better mental health. And we might encourage them to bring in writings that speak to them. So it could be biblical passages or self-help kind of writings or poems for those who are not religious. So they're using the intervention and in there and bringing it in from their outside lives. And the last two modules I'm going to mention briefly. Communication training we use to try to help people with this illness and their family members be better advocates for themselves. So we teach them a series of skills and how to approach things so they don't alienate others, but they're clear and concise about what they want. And we use this to lower the expressed emotion in the household. So they're taught to speak and make sure that they're really conveying the point it is that they want to convey, rather than generalizing to the person, and that they're listening actively, so that they are looking at the person when they speak, and before a person responds, that they're paraphrasing back to make sure that they are indeed hearing what the person said and not responding to some other thought that's in their head. And I say this for people with mental illness and without. In many families, even without mental illness, people talk past one another without really listening, and so they're thinking about what they're going to say and not hearing the other person. And that's confusing and lends itself to arguments, but it's especially confusing in people with mental illness who already have often many communication deficits. And so we spend a lot of time talking about cultural communication patterns, like what are the norms of communicating, and making sure that we're not encouraging them to engage in patterns that would be disrespectful, but also having them evaluate their patterns. And I'm going to say the same thing about the next segment, to really think about, we all have limited emotional and time resources, and so thinking about picking their communication battles wisely in line with their cultural values and beliefs. So, for example, I'm thinking of a case where the parents wanted their adult son with schizophrenia to go to church, and he was happy to do that, but he would often wear ripped jeans. And so we could talk about what can you live with, what can we let go of, and to free up time for things that really matter to you and your family. And so we teach them also to focus on specific behaviors. I really would appreciate it if you wouldn't leave your dishes in the sink rather than you're a slob, and things like that that are much more likely to trigger an argument and a shutting down. And then for the problem solving, which is the last segment of the intervention, we teach family members specific techniques to try to make them more efficient problem solvers. And so the most important thing is really to get them to operationalize what it is they want to work on. And you can use all of these exercises for individual problems and for family problems, but often we see when we do that, they're not even arguing about the same thing. And so we spend time saying and it's really hard to make progress on a goal if you don't even know what you're trying to work on. So we have them really decide and fine-tune, like you would with a research measure, what it is they're working on, and then we have them throw out all sorts of ideas from everybody without evaluating them. So good ideas don't get tossed prematurely, and sometimes a lot of knowledge comes from bad ideas. You know what you don't want, and there might be parts of that bad idea that are great. And so we teach them these skills. And here we talk a lot about their approaches to problem solving in their culture. And again, you don't have time to challenge, not everything needs to be labeled as a problem that needs to be solved. So picking their battles in line with their beliefs and values. So we tested this intervention, culturally informed therapy, CITS, against what we were initially calling treatment as usual. When I submitted this project for publication, a reviewer astutely pointed out that family therapy, only about 4 to 7% of people get, so it's way better than treatment as usual. We tested against psychoeducation, which is an effective intervention, so family psychoeducation. And just for our overarching findings, we found that our CITS outperformed psychoeducation. The lower bars are good scores because it's the variable that we were looking at for this graph on the left for you as well. The BPRS is a measure of psychiatric symptoms, brief psychiatric rating scale. We found that the families that went through CITS, the person with the illness, had less severe symptoms at termination. Now, this is controlling for their baseline score, and this was something we refer to as a median effect, so a really respectable outcome. And then for the family members, CITS outperformed psychoeducation, again, controlling for baseline scores on caregiver burden, and it was a large effect, so even more useful for the family members managing. And then we looked at other outcomes, depression, anxiety, and stress. We found that the intervention also outperformed psychoeducation on reducing those factors. But in this study, we found that the mediating variable, so the variable that really seemed to account for that improvement, was family collectivism, getting the family to really feel more cohesive and like a team had an influence. It didn't account for all of the variants, but it had a big influence on the improvements that we saw. In this particular study, in 2020 hindsight, we didn't evaluate religiosity very well because our goal wasn't to make people more religious. We didn't see pre and post changes in their religiosity. We weren't trying to. We were trying to get them to utilize their faith to manage their illness. So we didn't see changes in that. Cross-sectionally, we did see the more religious our clients were, the less severe the people with the illness's psychiatric symptoms were, the better quality of life on two different measures the family members reported. But we wanted to delve in a little bit more to why we might have not seen changes. And one of my students found in her doctoral dissertations that our religious clients were actually leaving us more often, were more likely to leave us prematurely. And she did something called survival analysis, where we looked at when the clients left, and found that almost all the participants, if they left, they were leaving in the early sessions, and at that point our spirituality module was in the middle of the treatment. The attrition rates dropped to 0. If they went through that module, nobody left. And so this made us realize we were probably, with our religious clients, missing a critical gap, and that we lost them before we got there. So in their mind, the intervention didn't align with their beliefs. And I should say we had really good retention, so it wasn't a lot of people that left us, but if those that did were more likely to be religious. And so the intervention does seem to decrease symptoms. It helps family members feel less depressed, burdened, and anxious, and this seems to be driven by increasing family cohesion, and I think the jury's out for religion. So I am just going to mention briefly, and we can talk more about this at the Q&A. We've extended this intervention. There's really only one module that's unique to schizophrenia, to all sorts of other populations and disorders. We offer multifamily groups where we now integrate religion from beginning to end. We start with a prayer or a reading. We talk about it in every session, and we are tailoring it to populations at high risk. So John referenced this. We just published a manual for Muslims because right now, for the last decade, Muslims in the U.S. have high rates of depression and suicide, unfortunately. So, and it's a population that doesn't tend to seek mainstream psychotherapy. So we're really working on that. And I think more importantly for today's talk, this is the last thing that I will mention, is my research team is just starting a project to really work with police officers to try to improve their relationships with people with mental illness. Tragically, about a quarter of all fatal police encounters do involve a person with schizophrenia or a related mental disorder. And, police arguably have one of the hardest jobs that there are, and the data shows that they're a group that has 5 times the rate of post-traumatic disorder. They have twice the rate of major depression. It's a really stressful job, and so it's not surprising. But what is scary about all of this is not only are their culture such that they're taught not to ever show weakness, so you would never seek psychotherapy, so they don't have an access to that. But our research is showing that the more that they are mentally unwell, distressed, anxious, suicidal, and the rates of suicide among officers is alarmingly high, the more likely they are to be stigmatizing towards people with serious mental illness. This isn't something bad or about officers. It's human nature. That's straight out of social psychology again. When we feel bad, we're meaner, we're more aggressive, we're more verbally and physically likely to lash out at others. And so it's really critical, I think, that officers get the support they need and deserve. They have a really tough job. They need to be educated more about the mental illness myth. We have data showing that they subscribe to that just like lay people. I mean, they're human beings as well. And so some of that through education from police force and the like, and changing the culture so that it's okay for an officer to seek help when they're depressed and stressed. I hope that we can also reduce this statistic, and I'll end with that. Thank you.
So Amy, someone who was watching online just texted me, is like, she's fascinating. So thank you so much. Yeah, I mean, she could keep going for, another hour or two, right? It's so much for us to talk about and engage with. So if you haven't written down questions, those in the room, get out your cards now and start writing. I've already written down some myself. But get those questions into me as you are listening to Todd for the next hour as well. We're going to take about a 10-minute break, and certainly continue to talk with those in the room. While we're on break, Todd is going to entertain us at the piano, by the way. So sorry. Well, those of you online, you'll get to hear it as best we can present it for you. But we'll take about a 10-minute break, and then we'll continue with Todd's talk next. Thank you.
Yeah, yeah.
I failed to say something. While you're on break, if you want to get on Facebook or YouTube and share the link to the stream, that would be awesome, just to expand the audience as we're doing this live. So look up Samaritan Gulf Coast on either one of those, and if you need help finding that, I will. Thank you. I will help you find that. Also, I forgot to mention Harmony Harbor, our sponsor and exhibitor in the back. They are giving away free prizes this morning, and they're doing drawings every 30 minutes. So share your card or sign up back at their table, and they have some giveaways for us. So if you haven't already done that, do that while you're on break. Thank you. All right, we'll get back into getting everyone focused on our second presentation. 10 minutes goes fast. I know I'm cutting off conversations back there, but I was talking with someone and real quickly, she's like, "Oh, I'd like to ask Amy such and such question. If you didn't get to Amy or Todd, in our breaks to ask them a question, that might be an opportunity for you to write it down on a card for us for our Q&A. Just another thought there, and you can get those to me anytime between now and good morning, by the way, for our third hour. I want to ask a question that I failed to do before Amy started. So sorry, Amy. I told you I would ask this question. I forgot to do that. I'm curious, for those in the room, how many of you are mental health professionals? If you'll raise your hand. If you're a mental health professional, okay, that's what I figured. We were about 50-50 in the room, so that's great. Okay. I think we know the answer to that question, right? So I do want to be a little more personable in introducing Todd. Just a fun connection here. We met through Facebook, actually, which is like, really? How does? Well, y'all know how that works, but I started following a running group online and noticed that this guy was posting a lot about mental health and running. I'm like, who is this guy? So I started, checking him out and saw he'd written a book, and he's going to, of course, Amy's already mentioned his book. So I got a copy of the book, and as I was reading it, just noticed that he said, "Hey, I'm coming to," just posted online, "I'm going to be running a race in Florida." I'm like, oh, I think I'll just reach out to him and just, see where that goes. So it led to him being here today and us connecting with Amy and putting all this together. So Todd has an incredible story that he's here to share with us, his story, but also give you insight to where his story has taken him in his, in his work with advocacy. And that's just as passionate for him. He's going to mention another book that has recently been published. So I'll give the floor to him now and give him all the time that he has. So please welcome Todd Crush to the stage.
Sure, I know how to work this. Okay. My name is Todd Arkyn Crush, and I will tell you that I'm a living example, living proof that there is no impossible, that with determination and love, support from mental health and family, we can overcome anything, absolutely anything. This first slide, you can see I did endure childhood abuse, primarily verbal abuse. There was some neglect and other isolation that happened to me. And you heard me playing piano. One of my coping strategies was, even at a very young age, at 3 or 4 years old, I would carry around, strips of white and black pieces of paper, because when I was isolated, I would sit there in the quiet and just play piano in my head. So it was a refuge from very early on. I struggled with that verbal abuse, and I'm really kind of skimming over this. My first book, From Beneath Ice, covers all this in extent, but we have limited time, and there's a lot I want to get to. That verbal abuse, that neglect, all left me with a very damaged and traumatized mind. I was removed from any sort of emotional content in relationships. Everything that I said or did as a child was used against me in a way often enough that I was afraid to put myself out there in any way. I also had that kind of worst case scenario thinking that developed, thinking that I was going to be a failure, that I was going to, end up just in a miserable state of life and relationships. I met my first wife and had some children in my early 20s, 3 children. And when I was 25, started having the symptoms of schizophrenia. This was in the 90s. The internet was very limited. I didn't really have any resources other than, movies like One Flew Over the Cuckoo's Nest, which is horrible, but that's all I had. And so I hid my hallucinations. I hid my trauma from everyone in my life. So to my wife and to my coworkers and my friends, all of a sudden I stopped running, and I stopped working, and I stopped doing all the things I normally did, and I started drinking more. I started acting erratically, obviously to things that weren't in the room, but they were reacting to, or I was reacting to. And eventually that unraveled to a point where my marriage dissolved, and I, had a suicide attempt, and I went into group homes and, encountered some other actions. This is also in the book. I don't want to ruin that for you. That really disturbed me and scared me. Again, nobody knew what I was really struggling with. And when I discovered some of these aspects that could possibly happen with this illness, with hallucinations and everything else, I didn't know what else to do. And I really felt like I tried to make in my first book the point that this was a bad decision. I should have gotten help. I should have sought out, and my life would have probably taken a much different turn. But I just left. I loaded up a backpack and lived in the woods for several years. So you can see the aspects and the elements of that journey. And, recently things have come to mind come to light that I'm going to get to a little bit later. But there's aspects of guilt to this illness that my second book is about, where abandoning my family and going off and nobody knew where I was for 2 years caused tremendous trauma to them, and then guilt throughout my life because our relationships never recovered. And that's a severe case, but all symptoms are severe to the person that's having them. One of the participants in my model missed his son's graduation. There's guilt there. And then there's fear of his second son's graduation. Does he go? Does he risk having an episode in front of, or symptoms in front of everybody and all his friends? So that's been a big part of this. I resurfaced in Arkansas in 2010, is where I live now. Came out of the wilderness in such severe psychosis. I didn't know my name. I didn't know where I had been. I had no memory of my past at all. I was like a blank sheet of paper, and it was the scariest experience in my life. I knew I had to get to the hospital, so I went to the hospital, and then from there went through what I'm sure a lot of the professionals here know and online, that I went through that hospital, home, hospital, on medication, off medication. I went through that whole cycle. In 2016, I was 297 pounds. And you can see the thing that strikes me about this picture. Everybody says, well, it doesn't even look like you, and it doesn't really. I run a lot, so I've lost the weight, but the light in my eyes, it's gone. There's no light there at all. I was completely dead inside, and I was in survival mode for a long time. So then I rose to become an advocate, as John said. I work with hospitals, with universities, to change the way we talk about and treat mental illness. The warrior is a big thing for me, because for me as a warrior, it's just sticks, right? It works for me. Some of these slides are. What I do is to promote wellness through running, through writing, all of it. Certainly, I've encountered so many people that I've worked with through running, but also through advocacy and talking with individuals like yourselves, that I think a big thing for running for me was with anxiety, especially and paranoia with my schizophrenia. I had a lot of difficulty leaving the house. I was agoraphobic. I just could not leave for several years after I returned arrived in Arkansas. Well, running was one of the things that allowed me to kind of use exposure therapy to lessen that anxiety. So obviously I don't have it now very much. I'm a little nervous, but not too much. And I think that running was a way, you know, at first when I went just around the block with anxiety or running and a hallucination would start and this person is running around and ringing doorbells and I just kept running through it. It's kind of like skydiving. If you do it the first time, you're going to be terrified, but if you do it every day for a year, you know, by New Year's, you're going to be jumping out backwards, you know, blindfolded probably. So let's get to a patient's perspective. This slide really represents for me, I keep wanting to walk over. Schizophrenia for me is, I only have about 4 or 5 hallucinations. They're repetitive. I'm sure I probably have some ones that are innocuous, like a car that isn't, you know, I didn't even notice. But what this illustrates is that for me, the way I explain it to doctors and everybody else is that we all have bizarre dreams. So in this image, even if I was a woman and I'm on a paper airplane flying over a city, that's really bizarre. But while I'm dreaming that, while we're dreaming that, we don't question it. It happens every single day. It's only when we wake up that our rational brain kicks in and we go, well, that was kind of weird. And then we tell our friends about it. But for me, the hallucination is the same way. When it appears and it happens all the time. I don't question it. I'm completely fooled and immersed in it. As my growth through this and my understanding towards it progressed, that rational brain kicked in faster and faster, to the point that on March 6th, last year was the last day I had any symptoms whatsoever, anxiety or anything else. And I remember it not so much because the hallucinations were kind of off and on, but the anxiety just stopped. And there's several things that I think contributed to that, and I'll get into those. It's helpful to me during hallucination, and I'm sure a lot of you know this, is calm voices, minimal touch, distraction. Distraction has been one of the biggest ones. And when I talk about distraction, for me, it was important to have things I could do anywhere. I do enjoy math, and I know a lot of people don't, but it's one of those things that interrupts our thought process. So if you were to try and add three-digit numbers in your head and also have a conversation at the same time, you can't do that. It's the same with intrusive thoughts or anxious thoughts. That process is interrupted. Good luck trying to get somebody to do math. Anyway, so anxiety is a lot of the same thing. One of the big things for me here was reassurance of safety, especially if I was in a crisis situation, if I was in a hospital or in an emergency situation with an ambulance. Reminders to self-soothe. I think a lot of times we talk about breathing techniques and doing math and things like that, but we do them in a crisis situation. But if we wait until that situation, it's not going to work. Our brain doesn't know. We're already we're too much into that panic state. We don't know our brain doesn't know where we're trying to go. So, a thing I did, I would do my breathing exercises right away when I woke up, even though I was already completely relaxed, unless I had a bad dream or something. And then my brain knew that process of where I was trying to get it to go. Okay, there. It keeps moving. Paranoia is a little bit different, and along with that comes some delusional aspects. Distraction is very good. The one I want to talk to on here is constructive failure. And if anybody wants this thing, I'll send it to you. I can email it to you.
Sorry, I forgot to say, a copy of his PowerPoints are in your bags.
Done. Thank you, John. Rockstar. So constructive failure is something I practiced specifically with paranoia, but also with other aspects, like with running further and further through my anxiety. Constructive failure is something so when I lived in my apartment, I was afraid to leave. I was agoraphobic, and I would leave. I'd set a goal to be outside for 5 minutes. I'd be out there, and I'd see a woman in the window, and immediately the thought would come that she's calling the police. Or I would see a guy going into the building, think he's going to put cameras in my apartment. Well, I would go back in, I would calm down, I would take out a notebook, and I would write down those intrusive thoughts after I was calm, and then I would write down rational answers. The woman is looking for her cat. the man is delivering a letter, whatever it was. And then the next day I would take that notebook with me outside with a new goal. And even though those intrusive thoughts might have been different when I read my answers, it reset my brain to rational thinking much quicker. So that's what constructive failure is. And I have a lot more of that in my book and my research of different aspects. The trauma from mental illness wasn't really present in any of my treatment. This is something that, could be any sort of event that's caused by mental illness, whether you leave work because you're in the hospital, or you drink too much and you miss a wedding, or, whatever it is, as your coping mechanisms. But the difference is, for me, is that, I had both. I had an abusive mother, but I can avoid that. I haven't talked to her for 15 years. And it's horrible. I mean, abuse is terrible, don't get me wrong. But if with time and distance, an external abuser, it fades a little bit, at least it did for me. That's not the same with my mental illness, because it's with me everywhere. It's like as if I was handcuffed to somebody that was doing that to me. That's why the coping skills are different. This is a main contributor to what my second book is about, and that's the repetitive guilt from mental illness. And that is what I had talked about before, with missing a graduation, with me abandoning my family, with what happened recently with my wife. I mean, all of it has been one guilt aspect after another. And I actually, came up with an analogy that I feel like all my loved ones are in the room and I'm a toddler playing with a grenade, because I don't see it coming, and it destroys everything over and over again. And that's hard guilt to live with over and over. So again, not addressed in literature. From family events to major hallucinations, I struggle with the consequences of this. We had no model for this. Back in, I think, March, I looked to see, we have the model for grief. We have the Kubler-Ross model for grief, but there's nothing out there really for guilt as far as a treatment model. So I created one. Now, you'll notice this isn't circular. It's, you can come at it every which way. And I also tried to kind of put things around in different ways. We have some neutral ones here, like apathy, detachment, I guess maybe sort of acceptance would be somewhat neutral, although it's a big step. You'll notice fear is on here twice. And the reason fear is on here twice is because, at least for me and a lot of the people that are participants in the model and thousands of people I've worked with, there's a fear of your own actions in the moment. But then even after you get through resolution or awareness or forgiveness, there's a fear that it's all going to happen again. And that has happened to me over and over. And a lot of people just, they can't keep going with that, which is sad. And I almost died several times. This is a quote from Voltaire. I think this says to me that we all try to do good. At least I think, most of us do. But what about the times where we believe we're doing good, and there's things under the surface or behind all that, which is what my quote is about, that, this is going to come no matter what I do. I just have to keep pushing through and understanding as best I can. I had fun with the transitions, though. It's fun. So how do we mitigate this? A big part of it for me was reprogramming that negative thought cycle that I had from my abuse as a child, and then also was perpetuated by my continuous cycle through stages and examples of my mental illness. Forgiveness and patience with myself was enormous. It's ongoing. It's something I'm really struggling with a lot now. Embracing new challenging situations was a big part of it. With running is a good example. Music is another good example. When I first met my wife, I could not even go to an open mic without, really struggling, without, alcohol and everything else, just to get up and play one song. And now I do, several shows a year with just having fun. So I think with that exposure therapy and with a lot of support and encouragement from loved ones, you can really change the game. The void is something I talk about a lot, and these next three here are big parts of that. I think whether we have mental illness or not, or whether we have trauma or both, what have you, a lot of us have that void inside that, you know, and maybe it's the things we did we regret, or maybe it's, you know, other aspects that were brought to us that we think about, how we think about ourselves or our place in the world. For a long time, I put, you know, relationships and cars and, you know, all kinds of stuff down into that, alcohol down into that void. But until I turned the other way and, you know, with Leslie, my wife, by my side, I was able to actually go into that void and look around at all the dark parts and accept them and be aware of them and forgive them and really move through. Now, that, as Amy said, you've got to have a good support system for that. That is easily the most difficult and almost excruciating process I went through. And I was lucky to have her support and a great medical team on my side too. But if that's not there, that is almost an impossible process. It's impossible enough if you are as supported as I was. And that's something in my advocacy work, when I work with individuals, that I really try to stress, because that, all of you know, the medical professionals especially, that's a very difficult process. So what does the guilt look like? These are the participants in the model. William was one of the first. These names have been changed. He presented with schizophrenia, detachment, fear, self-blame. He was living alone. The only communication he had with his family was letters delivered in the middle of the night that were kind of, you know, almost cryptic in nature. His fear, he missed his son's graduation, was left with guilt from that, as I said. There's a certain level of emotional exhaustion. Amy touched on that a little bit with families, where, you know, when I got involved with his process, I was actually working with his family. They were protecting their own mental health at this point, and that was a big part of the process for them. The second one was Sydney. She was a successful businesswoman, actually the main breadwinner of the family. Her depression got so severe that her husband said, all right, we're at ultimatum time. So he was either going to, you know, take her right then or go to the hospital. Her guilt came in that her doctor immediately mandated a leave of absence. Now, she had a certain amount of, you know, whatever, sick time and everything, but eventually it caught up. And that created a lot, not just in that, but her feeling of the stigma. What if my coworkers find out, or, you know, why they're going to wonder why I'm gone? And she had a lot of incidences with her family where she would, you know, yell at her daughter, or, you know, for really no reason. And these kinds of things really, even now, she's having a lot of trouble forgiving herself for that. This is the guilt from mental illness itself. This last one, and I'm going to touch on the violence aspect of this later, there is a perceived violence. I've never been violent in my life. Lucinda presented with depression. She was, you know, her family was very stoic, and I think this is something that I've kind of discovered, not just from my perspective. I'm 52, so my parents, that generation, was a World War II generation. You know, you didn't talk about it. We didn't want the family to, anybody outside to know what was going on. Sometimes even inside the family, you know what was going on. Well, that created this whole stoic kind of wall of defense that nobody talks about anything. And I think it's dangerous for everyone, and we're witnessing the crisis of it right now. But I think it's especially difficult for men. I have worked with thousands of people, mostly through Facebook and other places, individuals with mental illness, and probably 7% of them are men. I mean, just very few. And even those are more likely to just, you know, as Amy said, they come in, they talk to you, and then they're gone. And I had a statistic come across me that said men are 10 times more likely to carry through with a suicide attempt their methods are much more immediate and severe, typically, and they're 25% less or 40% less likely to tell anybody before they do it. And women are almost the opposite. So that's an aspect of this that, you know, I've just started to get into, but really tried to help with. Lucinda threatened her brother through a company email. She was in kind of a blackout state through her depression and also alcohol. Didn't know until the next morning when she saw her face next to the picture of the building being evacuated by the SWAT team on the news. So it wasn't violence, but it was threat of violence. Really quickly, sometimes she was imposed to go to AA. I don't have any problem with those kind of programs at all. I think in general they're a good idea, but I think sometimes what happens is, especially if you have someone that has mental illness and they get into one of those situations, all of a sudden they're coming from this level of trauma where they're feeling like a burden to everybody, and they get into that group and all of a sudden they're an expert. And they don't have to work on, they can just help everybody else, and there's this kind of removed action step that happens. I've seen it quite a bit. So what are your buttons? I was in a group home back in like 2000 sometime, and I was saying how my mom really knew how to push my buttons, and the therapist looked at me and she said, "What are your buttons?" And I had no idea. And it completely changed the dynamic between my mom and myself. All of a sudden, when I felt that anger rising or that defensiveness, you know, building, I thought, well, why am I feeling it? It became an educational experience versus fighting back. Above and beyond this, I think other people pushing our buttons is one thing. We can recognize that, but I realized just about 2 years ago through this process that I was pushing my own buttons. And again, that's something that I have to be aware of. Almost like if you think of the you know, like the Charlie Brown with the thoughts above his head over here, those would be the ones coming from the abuser. But if you move that bubble right in front of your face and you see your own thoughts and you witness those buttons being pushed, that made a big difference in my life. And I would journal everything, I would write everything down. So how did I go from being afraid to go to the mailbox to running without fear, running in other states, running this morning with John? How did I do that and stand here now with, you know, virtually no anxiety? And one of the big things, and caregivers don't like this, but, you know, we all know the phrase, you can lead a horse to water. Nothing changed until I decided I had to do it. That's the same through all of this with everybody. Everybody told me what I had to do, but it didn't stick. So what was the first thing? The first thing was becoming vigilant about medications and treatment. Again, that had to come from me. One of the things that I got initially from my parents when I was on, you know, things early on, like when I was 12, 13, all of a sudden I wasn't allowed to have any sort of emotional response without, I didn't get, "Are you okay?" or "How can I help?" I got, "Did you take your medication?" So it removed that human element for me that all of a sudden I was just supposed to be this perfect kid, and when it didn't fix it, then I felt like even more of a burden. Side effects, we all know about that. For me, I have a bipolar aspect to my illness, and when I'm off medication, I feel like Superman. You know, it's an amazing, you got to be careful with that, and but you know that was one of the main aspects for me. Accessibility is something I want to talk about in the Q&A. I hope somebody will ask about that. I've experienced a lot with lack of accessibility, not just from the system, but with my own anxiety. It was hard to go, you know, before COVID happened and we have all this telehealth now, it was hard to go to I mean, you can imagine somebody who hallucinates fire people jumping off the lawn on his way to get his medication at Walmart. How hard that would be to keep going to Walmart to get your medication. I realize I just advertised Walmart. Anyway, the delusion and confusion was bad. I had a delusion where I had a phone call with my doctor where she changed my medication. but it never actually happened. So I was taking my medication incorrectly. And again, I was living by myself, so nobody knew it. This slide is something that, for me, represents, here's a person with a ladder, and they're in a hole, right? The ladder represents medication. It might make me feel better. I might see the pathway, but I have to do the work. I have to climb the ladder. And what I'm talking about is there a medication that changes? I'm going to ask you, the medical professionals here right now, is there a medication that changes the way we think about our past, present, and future? I see a lot of no's. So why then are we treating people with medications alone and expecting this to happen? We need guilt aspects. We need those components. We need the treatment and the therapy. And I know that's hard to make people keep coming, but that's, I'll give you a really brief example. I was in the hospital for 3 weeks getting stabilized when I arrived in Fort Smith and in Arkansas and couldn't remember my own name. Spent 3 weeks stabilizing me. When I got discharged, I got a week of meds in a paper bag and a ride to the homeless shelter. What are the success rates for that? So one of the big final pieces was vulnerability with others and myself. This is my wife and I, and this is going to be largely unscripted. We divorced this year, largely due to the effects of confabulation. My brother reached out earlier this year, I think in March, and told us that there were elements of my past that were altered. The biggest one was probably that I had 2 backpacking trips of about 2 years, but in the middle of those, I was married for a year and then had a suicide attempt, but I don't have any memory of that whatsoever. Not that woman or her name or anything else. Well, this created obviously a tremendous rift of trust and everything else in my marriage. We have recently begun talking again, and it's been amazing. But from the beginning of my story, Leslie was there. Our first phone call, she wanted me to say, "I'm amazing," over and over. It was great. The impossibles were achieved together, encouraging, supportive. Again, things a lot of people with mental illness don't have in relationships, or that level of support. And that's something that I think, it was more than, and there's a dangerous line there, right, between enabling and being supportive. One of the things she changed about my landscape and saved my life so many times was that when I struggled or when I wasn't the best version I could be, she told me about it. She said, "Hey, here's what you could have done better with this." So Into the Void, that was what I talked about before with Writing from Beneath the Ice. That's my first book. I wanted to show you this. I don't have a slide of this. This is my new book, The Repetitive Guilt from Mental Illness. You can see the cover of this is abandoned cabin, and that's me standing through on the other side. You can look at that a little bit later. But with my relationship with my wife and with my kids and with basically my friend, every relationship I've had, this mental illness has created these situations where I build this house of joy and then I wake up one day and it's a shell and it's dark and it's scary and confusing and I can't see it coming. So this is something I just put in here about 2 days ago. I was talking with Amy this morning. People with mental illness, even trauma or both, are way more likely to be targeted by abusers. They already have social isolation. It exacerbates their mental health condition. Their reality can be undermined. So, meaning, well, that person has this, and that's why when the reports of violence or the reports of abuse can be seen as unreliable, or they're seen as the crying wolf, kind of person that does this so much, the authorities are going, "Oh, okay," and they don't actually have the training to help with that. So let's talk about stigma. I was in a hospital I had never been violent in my life. I don't think I even had a playground altercation with anybody. But I worked with a family that had a father who had dementia, and he would attack them when they came home because he didn't know who they were. Well, I've had hallucinations of people breaking into my apartment. Now, I would barricade myself in the bathroom with a knife or whatever. Now, those are different illnesses and different situations, but I was in the hospital, had to go to the courtroom to decide whether or not I was going to be voluntary. I was put in a jumpsuit with handcuffs, waist chains, shackles, and chained to the floor of a van and walked through the courthouse with an officer on all four sides. Like I felt like, and this makes somebody feel like a burden, like a criminal. Imagine if we did that to Grandpa when he went to the hospital for his dementia. And even the family is seen as different. His family gets compassion and understanding usually, and they get, can we help? Leslie got, are you sure you want to deal with that your whole, it's a very different stigma. She touched on this briefly. 4% of violence in the United States can be attributed to mental illness. And this is perpetuated by media, not just shows. I know there are scary shows like Criminal Minds, and that's the whole point. But there's such limited exposure to this. I've been on the local news a couple times, and I had to fight really hard to get there. Now, if I committed an act of violence, I guarantee you I would be on there without any effort whatsoever. And that's the difference. Mental illness is the only thing we treat people for what they might do. The only thing. This is something she touched on as well. I actually have her, we kind of duplicated here, but I think it's worth saying the 25% of fatalities. Running did a lot for me. My wife did a lot for me. Writing did a lot for me. All those things took me from thinking I could be strong to proving I was every single time I was out there. Failing constructively. And this is the bottom shoe. I don't know if you can read that. It's my first run with Fred, who's a hallucination. And that was a day where my wife, I went out for a run and I came back in like 2 minutes because he was out breaking windows and everything else. And I went in and I played music for a while, and then I came back out and I was like, he's still there. And I said, yeah. And so she said, well, why don't you go out again? And I did, and I ran, and by the time I was done, he was gone. No, I'm not advocating that at all, that you shouldn't take your medication and you can just run this away. That doesn't work that way. It's a all-over approach to all of it. But it certainly was something that, again, like the slide with the ladder, you have to do the work, and whether that's running or knitting or playing piano or going to church, it doesn't matter. You have to do the work because the medication just isn't going to do it by itself. I guarantee that. I want to talk briefly about purpose. One of the things I struggled with a lot, I was on disability. I couldn't leave the house. I couldn't, do much of anything. And I had no purpose. My purpose was to be alive the next morning. And, as I started kind of emerging out of this and starting to be in public with my wife and her daughter and things like that, what's the first thing people ask you when you go to a school event? What do you do? Well, what do you say if you're, well, I kind of do what I need to do to cope so I'm alive the next day. That doesn't, yeah. And this will demonstrate the stigma. One of the first times I went to the open mic to play music, somebody asked me that question, and I for whatever reason, I just said, well, I'm on disability, and she kind of went like that, and so without even being prompted, I said, well, I have schizophrenia. She stepped back, which is just the most powerful image of stigma that you can have. But now, I have purpose. Obviously, I'm here in front of you, and this is what I do. But that's not common, And I think a lot of individuals and participants I've worked with mental health, they are on that oscillation between, good and bad times with purpose. And it's very important. I mean, I feel like you have to have something. I don't know what the answer to that is. I don't know if we can incorporate something like that into treatment centers where we give these people projects or, whether it's exercise or what have you. I actually got a donation they have these rollout keyboards that are flat. I'm going to start sending them out in January. I got 100 of them. And so I'm going to be putting those in hospitals and treatment centers and things like that because, here's a trick for you. If you want to sound pretty good on the piano, just all black keys because it's a key minus one note, but if you just stay, it'll sound good. But the aspect of that is if you have someone that's really struggling and needs that, music does the same thing that math does. It's the same center of our brain. Roll out that keyboard and they can go in there and detach from all their trauma and make something beautiful in that room, and they'll probably come out of that with more than they did with, almost anything. At least that would have been it for me. I went to one hospital where they actually had a piano, and every day while people did art, I played piano. And it was like the best thing about that whole experience. Because what happens in groups, in therapy, in hospitals, the food is terrible, and it's non-productive usually. At least it was in my experience. I missed the little button there. This is one of my favorite quotes. It stands by itself. And I think this goes back to purpose. What I did for myself was all I did. And for a long time, I think I came out of that with a real self-centered, selfish kind of defensive nature, where I felt like I was used to doing whatever I had to do to survive. I was in that fight or flight mode. I was in that survival mode. Well, that's hard to move out of when you start to feel better. One more thing about that real quick is that I think one thing I've noticed, and I know that a lot of you here are probably in more of a crisis situation, but I think there's an element to this that I've experienced and that I've seen in a few others where as wellness happens, as that person moves towards resolution, as I got healthier, the dynamic of my relationships changed. I had a friend, he's in my first book, Craig, who was always the one helping me. I don't know how else to do it. He wasn't above me, but he was always pulling me up, helping me out, checking on me, making sure I was okay. And then all of a sudden, when I started doing what I'm doing now, and got to the point where I wasn't really needing that, he actually reached out and started sabotaging by bringing up the past and all these things because I think he wanted me to be backward. He didn't understand for so long. I don't even think he knew he was doing it, but for so long his identity was to be that helpful, strong person. And I've seen that a lot with caregivers and parents, especially parents, where they get that target fixation that they have to secure wellness for their child, and when that isn't necessary, they kind of lose their purpose. So the purpose and that dynamic is on both ends of that spectrum. There we go. Thank you. If you have any questions, please do let me know. I know we're going to do that here in a bit, but I wanted to thank John and Amy for everything, especially working with both of them through some of the questions I've had. Amy and I talked at breakfast this morning about how she's got a very clinical side and I've got a very, almost soldier on the ground kind of in the battle kind of side. And the two of that is it's really powerful. So thank you so much for coming. And that's it. Thank you.
Again, it's like, oh, we could just sort of sit here and just take it all in. It's good, but we need a break. So you got about, let's take let's take 15 minutes this time, and because we got probably more time than we need for the Q&A, but we're glad we have all this time. So certainly make sure, I already got one card from someone. If you've written a question or two down, however many you have, just get that card to me in the next 15 minutes, and then we'll roll with our Q&A for the third hour. Feel free to get, for those in the room, feel free to get a drink or a snack as you need in this next 15 minutes. Thank you.
Just those two. The event runs smoothly.
We have three, I forgot. Yes, because this one I brought with me this morning.
All right. Amy has told me multiple times this morning, like it feels like a luxury that we have this amount of time for a Q&A. So thank you for your questions. And I mean, honestly, if we don't last the whole hour, that's not the end of the world. Then y'all can still mingle, and we have the room till noon, well, past noon, but whatever. So I'm going to go ahead and get us rolling. If you did have a question that you didn't get to me yet, just feel free to walk up and hand it to me. Totally cool. And some of these, we're interacting here, but some of these are going to be more specific to one of you. But certainly fill in how you would like. But Todd, let's start with this question. When did you even realize what it was that was happening to you? Was it pre-wilderness, post-wilderness? How could you describe that?
It was.
I have no idea. Go ahead. Nope. You want to come check him out?
We'll just trade. Yeah, I was when my schizophrenia first presented, I was 25. This is in my first book. I was home alone. I was, in the dining room working on a piece of furniture, and I looked out in the driveway, and there's this girl standing out there talking, like a 11, 12-year-old girl, and so I went outside to see if she needed help or if her parents were around, and she was talking, but there was no sound. And I thought that was very strange. So I went back inside to get the phone to call the police or whoever, and I came back out and she was gone. Well, I thought at that point, well, maybe she's, lost, or she ran off to where she was supposed to be. But it lingered, like, why was she talking with no sound? And maybe a week later, I was watching TV with my wife and kids, and I walked back through that dining room, and it was at night. We were watching a movie. I was going to get snacks, and I'm getting chills because when I turned the corner to go through that room, she was standing in the dining room, and all the doors were locked, and that was when panic started, and I knew something was really wrong. Yeah, so that's when I knew, and again, the stigma was so bad. I was so afraid of being locked in an institution forever that I didn't say anything for 15 years.
And sorry, you may have said this and I missed it. How old were you at that point?
25.
25, okay. From the same submission here, taking a turn toward running.
Okay.
You mentioned running a race here in Florida, just out of curiosity and for fun. What was that race?
I ran the Long Haul 100. It's a 100-mile race out in Lakeland, right?
Mm-hmm. Yep.
I made 51.4 miles before my knees were pretty bad. I had it was my first 100, and I had kind of a training mishap where I trained on, mostly on pavement. And that race here in Florida is very soft, kind of sandy almost surface. And so if you think of it, you need to train on whatever surface you are racing on, not just trails to pavement, but even soft dirt, even if it's flat like a sidewalk. If you have a tennis ball and you bounce it on this wooden floor, it's going to bounce back quite a bit. Well, your legs don't have to work as hard with that kind of rebound. Well, if all of a sudden you're bouncing that ball on soft dirt, it's not your legs have to work pretty hard. So, but I'm grateful to John because when I met John, he brought my wife and I, he met us at a Starbucks with a cooler and some chairs, which if you've ever run a marathon or longer, you know that a chair is, ultra athletes have a saying that says, beware the chair. But it was nice to be able to sit somewhere and have a cooler with cold drinks. But yeah, just train on the surface you're running on.
So along that line, do you find the endorphins from running are your best drug?
I'm going to be careful with that one. Medication is important. All right. But no, it is. I've actually worked with a couple doctors that have, not for my own treatment, but through my research and everything, that there's some more than the psychological aspect of outrunning mental illness. I think there's some research that's starting to show it helps your body absorb your medication better. You know, you've got more blood flow. And like Amy touched on in her presentation, like spirituality, something like running fosters health everywhere. You eat better, you drink less so you can run better. So it just built like that for me. The endorphins, yeah, just being able, for me, I don't know if it was actually the running itself, but I was locked in so long in my apartment and just afraid to be in society at all, in public. To be able to go out and run on a mountain or in California next to just with no, that was the endorphin high for me, was just be able to do that without anxiety.
All the non-runners in the room like, yeah, whatever. I just did a 100-miler, whatever. Amy, for you, you mentioned the 5-minute speech sample. Can you tell us a little bit more about that?
Sure. So the gold standard for measuring expressed emotion, that construct that I talked a lot about in my talk, was an hour-and-a-half lengthy interview, and so because it was such a helpful tool in figuring out how patients were likely to progress, we needed a more efficient way of measuring it, and so a group of researchers led by Anna Magana and colleagues developed something that was a 5-minute version. Literally, you ask, tell me about Todd and how if I'm your sibling or parent or whoever is in the treatment, and how the two of you get along, nothing else, and then it has a operationalized coding system. So the certain number of criticisms that come out or generalized hostility, and it's not quite as sensitive. The threshold isn't as good for detecting high EE, but it has good concordance, and it's 5 minutes as opposed to an hour-and-a-half. So it's a really helpful tool if you're doing research on a bunch of constructs, but you don't want to not measure EE.
Is that helpful? Where do you find it?
I can send it to you. Anna Magana is the author, and so you could find it there, and that is the prompt. So the coding manual is harder to access, and there are some copyright protections, but I can certainly send you the prompt. That's outlined everywhere, so to see what the instrument looks like.
So a different question from Stephanie regarding religion. What are your suggestions, and either one of you, but how would you suggest family members handle different religions, when you're dealing with that whether it's family or whoever?
You would think that, was it you that asked that question, that it was planted, because I love that question. When I was developing culturally informed therapy, I was really worried about that. Like, well, what if one is atheist and one member is Christian or one's Jewish? And so, we decided that, you people are going to set their own homework assignments. They're going to, you can be working from the non-religious handouts, and another person can be working from the religious ones. But we thought that might create a lot of tension, but it was actually amazing. More often than not, the family members loved learning more about the other person's faith and beliefs, and so it ended up being a way that they're getting to know each other better. It's not like they didn't already know they had a different faith, and so it was a way to get them to think about, that's really interesting. I didn't know that. So it wasn't a struggle at all. Now they might set different exercises for themselves, and one exercise might even be to learn more, because that's the whole goal of the intervention, is to get them to see themselves as interconnected. So one goal could be to attend each other's services and learn more about it, and that's one of the activities to get them to, and it's, we often say we want them to have commonalities, but it's not the goal to be identical. It's what makes relationships interesting, when we have different knowledge sets, when we have different ideas about things. And so I was very worried, that's going to be a challenge, and it was actually as easy and often more beneficial than when you were working with the same faith.
I find that interesting for a whole bunch of reasons, but it seems to me that the reality that if we can just listen to one another, back to that active listening, one of you mentioned that, just listening to it, one another, no matter, even if it is a sensitive, so to speak, topic, religious or political, whatever it is, just having that respect for one another is going to help the conversation happen. Do you have anything to add to that?
Yeah, I was going to add real quick. From my perspective, I've never really struggled with this, but I've had a lot of people that I've worked with and known through groups and things that struggle with schizophrenia or similar illnesses that at least specific to schizophrenia, there has to be a little bit of a caveat there, because there are often godlike ideations, whether it's God talking to them or that they're Jesus or Buddha or something, and that is something that prevails a lot with schizophrenia. In general, spirituality for me has been, the mountain is my church, and that, there's a section in my book where I was having a near-death experience, and I won't spoil that for you, not because I want to sell books, but it's fun to read about it. But I think that there's the religion we hear about in church and from our parents and whatever it was, whatever it is, that's great for everyone. But I think there's something we miss if that's all we get, and we don't. I felt, and more throughout my life with all these experiences, that especially with mental illness, that there's something there that's not, it doesn't have a name or any kind of books or anything else. It's just between you and me and the trees and everything. It's just there.
One thing I think is important to add, and I usually in this talk I mention this, in our treatment, if somebody is, we operationalize this by using an instrument, the brief psychiatric rating scale, but if they're what we call like floridly psychotic, if they're scoring a 6 or a 7, we send them out to get a medication consult. And if they're having religious delusions, but they're lower level and they're still able to engage in a cognitive behavioral program, we'll treat them, but we go automatically to the more secular handouts, because by definition, delusions are not rational. And so it's not helpful to be that if they're believing that they are Jesus Christ themselves, and the first thing you learn when you interact with people with psychosis, if somebody's having a delusion, it's real to them. You don't challenge them. You work around, or you digress and move on. And so we didn't have that problem often because we required them to be stabilized on medication, and because we know when somebody's really psychotic, they can't engage in sort of the reality testing and things that's required of our intervention. They can certainly do other types of interventions and take their medications. And so we are not treating somebody who's having a religious delusion or experiences with a religious intervention. I think that's really important. I usually talk about that. I had to cut out some things to meet the 45-minute goal today, but
Which is why we're talking now,
Yeah,
to
there you
fill the gaps.
Can I ask you a question? Have you had it where it goes the other way, where the person goes into the religious experience and then the delusion happens?
So when people, I think you alluded to this, and I love the comment about dreaming. When people dream, they distort reality. You said that in your talk today. And so when people become psychotic, their reality is based on what their real experiences are. And so they might be, it's just like somebody who has, they're a highly anxious person, and they have a critical family member, and then all of the sudden the extremes of that critical family members, they think that family member's trying to poison them when they are harmful, but that piece of it is a delusion. And so somebody is religious, they are more likely to have religious delusions because that is their day-to-day. We don't dream about things we've never experienced. And so it's sort of an exaggeration of one's reality, and that's what makes it a psychosis. And so, yes, religious people are more likely to have religious delusions, and athletes are more likely to have delusions that are related to their sport. So.
So staying on this theme a little bit, just a different twist here. This question, in your studies, either one of you, did you encounter schizophrenia being viewed as demonic in religious families?
No, I have not. No.
That was another thing, because some of the bloodiest wars are fought in the name of religion, that you would expect to see more of now. It was more of the Spanish-speaking families, and they were talking about it as this will help us get through that, and it does happen. I mean, I hear about, I do a lot of work in the LGBT community, and they talk about their families, viewing them as, and so it definitely, there is the potential to use religion in really awful ways. We didn't see a lot of that, and we used the religiosity segment of the intervention to work with maladaptive uses, like saying your illness is a punishment from God for misdeeds, or the other thing that does happen a little more than that is saying God, it's in God's hands. We don't need to do anything. I don't have to take my medication. God will cure me, because that is not productive. And so then we'll ask them about passages from the religion. God helps those that help themselves, and that's usually a way to kind of encourage them to find passages or make interpretations that help them lead a life that we know as mental health practitioners can really help, but it's a life that's important to them. Only they get to decide what a meaningful life is.
So going now into some questions about working with particular people and families. In young adults and late teens, what is an early distinguishing feature between schizophrenic and bipolar with psychotic features?
Mm-hmm. In any one point in time, those disorders are so hard to differentiate because I mentioned this during my talk. If you have schizophrenia, even if you don't have schizoaffective disorder or bipolar disorder, it's hard. I mean, you heard Todd's story, and so it's more normal than not to have affective components. The definitional kinds of things is which one predominates. Like if you are only seeing mood symptoms in the midst of a psychotic episode, that's going to lead you more towards a schizoaffective disorder, and it also depends on the amount of times, or schizophrenia that is impacting a person's life and making them depressed and sad at times in ways that most of us would. If it is the mood symptoms that predominate, and occasionally, and this happens a lot when somebody is really in the midst of a very serious manic episode, they often are psychotic. They wouldn't necessarily get a diagnosis of schizoaffective disorder if it's the occasional. So those disorders are close cousins. So if you see, often you'll see family members where one member has bipolar and another has schizophrenia. So they're, and if you kind of need a history, because it's difficult to distinguish between, is it schizophrenia and is it a mood disorder? And the main reason that it's important to distinguish is for medication. Our treatment would work just as well for bipolar or for schizophrenia, and we wouldn't even need to modify the education component that much because they're so similar. It's just that the biochemistry is a little different, and so that's really where that distinction is important. And sorry, the question was about young kids.
Right, young adults and late teens.
So just to say, you will see more of the irritability, more of the depression, moodiness, sadness in those that are more in the affective disorder spectrum, and you'll see more of the, schizophrenia doesn't usually onset until age 18 or so for boys, and often after 20 for women, but you will see some of the negative characteristics. Kids are often, they don't socialize well, they don't make great eye contact, and so those, that's how they look a little bit different as before they have their, first break, that we call it, when they're diagnosed.
I want to say something about environment with that. In my own experience, you all know that I did not reveal my illness. So, if you break your leg and you go to the ER and you tell them your neck hurts, you're not going to get the care you need. And I've worked with parents of teenagers a lot, and one thing I've noticed is that when I think there's a big environmental difference between when I was a teenager struggling with mental illness, or if I was bullied or something like that. Like, if take bullying as an analogy here. If you're bullied, the only people that knew about it when I was a kid were the people next to your locker. Now, if you bully somebody on Facebook, millions of people see it. Now, if you bully somebody about their mental illness, are they ever going to reveal that ever again? So that's got to be hard for everyone to try and figure out what's actually happening if the environment is that volatile.
Can I ask Todd a follow-up? Do you feel like it's getting better? More of these conversations and...
A little bit. I mean, I think there's a big movement right now for youth, junior highs and high schools, middle schools, high schools, where there's a lot of education. Is it changing the dynamic of how those kids are talking to each other? I don't think so. Maybe a little bit, but I think in general, I think what social media has done is it's kind of removed compassion. Like, all of a sudden everybody has a microphone and everybody can say whatever they want. But, in general, I think that a lot of times the kids I've worked with that have experienced bullying and all these negative aspects, they feel hopeless. They don't, and you said they're already kind of withdrawing to begin with, and this just even further pushes that down. So no, I don't think it. I mean, there is a movement as far as like through schools and through parents and groups like that, but I can't say that I've seen that it's really changing how the kids are feeling about what's going on with everything.
So a second question from this person, it goes to how does a family get referred to the CIT program? Is there a way for families in Sarasota to get referred to it?
We were running trials for about 10 years, and now we're talking about getting it into, for example, I was just talking about, I have a student placed at MGH in Boston, and getting it there and into communities. This is what I was saying to both of you earlier. We need to be getting it implemented. And so we run trials, and because you're in Florida and I'm licensed in Florida, I could see families over through Zoom. I'm licensed to do that, and out of state lines I'm not. But I am starting to try to get it out in communities. I know you're connected with counseling movement. That is something I'm hoping to have it in more of the clinics that are local, that are run by local people. And so at the moment, that would be challenging because we ran clinical trials for 10 years, and we're switching over, probably running interventions next for police officers. And so at the moment, that would be challenging. But reach out to me, because we're working on that.
Which we haven't shared email addresses and that kind of stuff. Maybe before we finish, we should do that. That would be helpful. Since you just mentioned police officers, I'm curious, and this is for both of you, based on your experience and research, what gaps need addressing for those in the first responder field?
I've had several personal experiences with emergency situations where I was the person involved with police and fire. Generally, they were neutral at, for the most part. I never really had any other than, being shackled to go to the courtroom, but that wasn't really an emergency situation. Everything else was pretty good, actually. I have spoken with a few police departments and fire departments, and I have encountered kind of almost a barrier there, where it just doesn't seem like there's interest or funding or anything else, and that's unfortunate, because Amy and I were talking before this. I have worked with a lot of individuals that have encountered unfortunate situations or situations that could have been handled better by emergency services. Again, it's a very difficult job. Let's take the example of somebody, you know, I mentioned the example of me being attacked by little fire creatures when I was on my way to get my meds. Well, to everybody responding to that situation, I'm nonverbal. I'm rolling around on the ground screaming. I'm either, you know, on some sort of drug or I'm having a mental. How do you figure that out as that responder? And I think, you know, one of the things that we're just really starting to talk about this aspect of it, but as opposed to, let's say, if I'm approaching that situation as an officer and I ask the individual, are you on any drugs? Well, that's almost immediately accusatory in a way, or assuming at least. What if that officer said, who's your doctor? Because if the person is having a drug crisis, the response is going to be much different than if you have a mental health person. They're going to, you know, and there it's a win-win, because now if you do get the name of the doctor, now you can really connect and really get that person help right away. So I think a lot, and we're just in the beginning of this, but I think those kinds of things are really something that we can get into the hands of, and the officers just generally don't have the training at all. Is like in the slide I had about the response in a domestic violence situation. If one of those individuals has mental illness and the officers have been responding to this house over and over, they are not going to take the complaint or the what would it be, the report the same way. And they just don't have the training to respond to that. And I'm encountering not just I've had fundraisers. So, and I don't ask for a lot of money to go talk to police departments, but their budgets are so limited, they just don't have money for this.
How much time do I have? This is actually a topic that I'm really interested in. I'll try to say this concisely, but you know, around 2020, there was so many high-profile deaths with people like Daniel Prude at the hands of police officers. A really tragic story. A relatively young black man who his brother called because he was suicidal and having a serious episode. He called the police for help, and they came and put a spit hood over his head, and he aspirated, and within the week he died. And you know, there was also George Floyd, and so I spend, and I showed that statistic today, about 25% of the deaths are people with fatalities at the hands of officers are people with serious mental illness. And I was thinking, you know, we have to advocate here, and so I became really interested in what we could offer as mental health practitioners, and I went into it from the angle of, I've spent my career trying to improve the lives of people with serious mental illness. And then I spent the last 2 years interviewing police officers and talking to police officers, and I alluded to some of this research, but they have the toughest jobs. They are underpaid, overworked, and so and because of the things that they see day in and day out, they are clinically depressed. I double the rates of lay people, and I mentioned this already in my talk, 5 times as likely to have post-traumatic stress disorder. And I won't reiterate all of the research that shows just dealing with that is going to make them less aggressive in their day-to-day. Now, I spent the last 2 years interviewing them one-on-one, asking what can we do to get officers actually to take those intervention programs. And I asked them specifically about interacting with people with mental illness as a sideline of questionings, and they do say, we don't have the training for that. It's getting better. These crisis intervention researchers are implementing training specifically about serious mental illness, and we are seeing fatalities decrease in the cities that have them. And so they are doing great work, but it's too slow. And so I think we need to intervene in both having at the level of the force to train officers about the things that Todd mentioned are helpful. When you approach someone and you think they might have a mental illness, you don't use your command voice. You say, how are you? How are you doing? That doesn't mean they don't have to protect themselves. And if they must draw a gun, that should be the last resort. But learning how to interact with people with serious mental illness, but that is a different question than changing the police culture so that it is okay to seek help. They are taught that they cannot show any weakness, and they internalize that. If they acknowledge that they need help with their trauma, then they are at risk of losing their job. And so police officers told me it has to be not only completely confidential, because there is the worry that it'll filter back to the police chiefs and they'll lose their jobs. It has to be separate and off-site. It has to be that there's no documentation, so that these are logistical challenges through how insurance reimburses them. They have to be able to say, hey, I had a traumatic incident in the line of duty. I need, a week of mental health time, and they need to be compensated for that time. And so I think really I never went into this, with the idea that we need to work with police officers and tell them to stop killing people with serious mental illness, disproportionately Black men. That was where my heart was, but I always knew that they have a important and horrible, probably arguably the most stressful job there is. But through it, I realized, this is a population in need, and a population that is very unlikely to seek help on their own. And so I think finding out what are the barriers, and I have a lot of ideas now because I've been talking to police officers, what would make you more likely to be okay seeking help. And also one thing that is outside of the realm of psychology, I think you mentioned it, but they are so in the media, they are the enemy. And I have to say, it's any deaths at all are too many, but 99.9% of their interactions with people with serious mental illness end smoothly. So we do have to recognize that as well. So I'm feeling now I'm going to try to make my role as the advocate for both groups, because if police officers' mental health is better, there's going to be fewer deaths of everyone. That's just a fact.
What both of you have illustrated to me, and I think the group this morning, is advocacy is so important. Whether it's from the research training side, whether it's from the lived experience side, or whatever side. If you're a family member and your family's walking through any of this together, advocacy is so important. Which leads me to this question you've mentioned several times, the Black population. So here's a question. Could you speak more on schizophrenia within the Black population and whether there is a tie to epigenetics?
Mm-hmm. Most likely, yes. It's a complex disorder, and so things get passed down. So trauma gets passed down, and your brain chemistry changes when you experience discrimination, poverty, and all of those things. So some of that is probably passed down in that way. And then the environmental components. I said this in my talk, but I think it's really important to underscore the fact that the only places where Black people have higher rates of schizophrenia, in African countries, the prevalence rates are the same or lower. It is a function of the environment in which they have lived. Some of that could be an epigenetic pathway from poverty and experiences that change the brain and the genetic coding, if you will, of their parents, and then their parents' lack of resources and their own understanding of how to manage these illnesses as well. That has an environmental component. So it's absolutely both things. I think the research on the prevalence rates tells you a lot about the fact that the differences that we see are likely environmental and genetic, to the extent that the parents that pass on the genes were the victims of the same environmental and institutional barriers that Black people face in this country. So I don't know if that was a...
Well, let me do a little caveat there, because I know last year, for those of you who weren't familiar, we've done, we meaning Samaritan, has offered an event the last 2 years called Integrate, which was a whole day of this kind of stuff. And anytime we've done anything on epigenetics, the room was full. And everybody's like, we can't get enough of it. So I'm curious, from your perspective, either one of you, is there still a lot of help that we feel like epigenetics, or, understanding it, leaning into it, is going to benefit us?
You know, I think there is room to be done. We know it's genetic. It has a 80% heritability factor, but we still don't know which genes. And there could be some, we have amazing technologies. If we can isolate the genes, we might have a better way of figuring out how do we respond to that. That could even feed back into things we already use, medications that need tailoring and different kinds of targeting. And it could also help counsel people better who have the illness in their family. So I think that work will be amazing. Probably in my lifetime, the main improvements in management are going to come from better access to psychotherapy and better medications. They've gotten a lot better since even the 30 years I've been in this field. But that, I think, is probably going to have, in the short run, a much bigger impact on the day-to-day lives of people. But we need to do it all. So I do think there's some benefit from continuing to figure out,
So let me use what you just said and segue us into accessibility. Help us, Todd, from your perspective, get a feel from your experience. Where are we? How do we sit when it comes to accessibility?
I think COVID was good and bad. I'll start there. COVID isolated a lot of people, and it created a lot more mental health difficulties than we had before. But it also opened the door to telehealth. And like I said in my talk, that a big thing I struggled with is that not only did I have, so a lot of people who are on have mental health struggles are on disability, and a lot of them live alone. Well, I didn't, because of my schizophrenia, my license was suspended, so I, wasn't driving either. I lived in Arkansas in a town, and there were 6 mental health facilities within a mile of my apartment, but none of them accepted Medicare. So I had to take an Uber 30 minutes north twice a month because Medicare doesn't let you have more than one appointment on one day. So 4 Uber rides on a limited income, plus having to walk into Walmart, which has more cameras than anywhere else. I guess I'm shaming them now, but there's cameras everywhere, and that's difficult for somebody with anxiety. Not just the cameras, but going to public. And I think, touching on what you said about self-medicating, if I have to spend $120 on Ubers to go see those places, and then I have to walk to Walmart past all those people and cameras and everything else to get my medication and then pay for my medication, and the liquor store is a block away, and then the system itself, I was on a program years ago where I was getting my medication for free, and I have to be careful about this because I'm not a doctor, so I can't name the names of the medication. But I was on that program getting it for free, and all of a sudden the company changed or eliminated the program, and I went from $0 to $1,000 a month, which was like twice my income at the time. And so I switched medications. It actually worked out better for me, at least for the medication side, but how often does that happen?
Right.
And why are these programs just changing all of a sudden? So I think accessibility is better as far as like appointments and going to see doctors and things like that, but I think there's a long way we could go towards making it just easier for people to access treatment and meds.
Yeah, I think some of that is even at the level of it's impossible to understand where you're covered, where you're not covered. And if somebody is mentally ill, it's hard to navigate that system. I mean, I have a PhD and I sometimes don't know where I'm supposed to go for what thing. And so I think it's part of the accessibility is having the information that's out there that people can understand and then also I think COVID, we were doing the CITS intervention then, and we got shut down and we moved online, and I thought, oh, this is going to be terrible, and it was wonderful. People could get there. Our attrition rates dropped a little because they weren't fighting traffic, and so that actually, as Todd mentioned, was reduced one of the main barriers to access. So that turned out.
Yeah, you generated something for me too. I think that, at least from my perspective, the devices and things were good and bad. Obviously, I don't have trouble with that now with cameras. I actually have 2 cell phones now. I didn't even have a single cell phone until about 5 years ago, or 6 years ago, because I was afraid of being tracked. I think there is a barrier there. If somebody is, the only way they can access where they can go or having an appointment is through a camera, that might be hard too. And like you said, the system is difficult to figure out if you don't. And people on disability may not have a fancy computer or a phone that they can just look at.
And I think loneliness and isolation is a huge component of this disorder. And so I don't think one replaces the other, but it's really nice to be able to be seen if you can't make it in. But there's also some benefits for periods of your life. I think, that might be the only interaction somebody has. And so that's, it's helpful to be able to choose. Some people, as you said, are fearful of the cameras, and some people just want to sit across the room and look at the person that they're talking to, and that's therapeutic in and of itself. And so, we need to have more choice, I think, and it needs to be how you decide what your resources are. Just needs to be made clearer to people.
Yeah. Got a couple of questions about getting into intervention and the guilt model, but before we go there, take a little breather here. Todd, you have more than once, either through your social media post or just our conversation, you've talked about the importance of joy. Tell us about that.
Yeah, we were talking about that this morning. Roosevelt said that comparison is the thief of joy, and I've encountered that a lot in running with people I train as well as, work with. And I've encountered that as an advocate for mental health, either people comparing that, well, I've never run that far, or I'm only running this far, or, well, your disorder is worse than mine, or it doesn't matter. It's all relative, and everybody's difficult is their own. Joy is something that I don't even wear my watch when I run anymore because it doesn't matter. I just go out until I'm done, and then I come home. And, I found that thief of joy creeping in, not just from comparison of myself with people that were doing things years ago in my life that I was, not able to do. And I told my wife, I told my friends, I just want to do, and this is a horrible word, but I just want to do what normal people, or what everybody else does. There's a lot of things, and I think there's a perspective there that, is not really understood, that a lot of folks take for granted going to a restaurant without anxiety or paranoia or, whatever it is. And that's a thief of something. And then that person who can't go is comparing themselves while they sit at home to everybody else who's off having a good time. And it's hard. I mean, a lot of times, to circle this back to running, a lot of people are like, well, why do you run so far? Why can't you just run 5 miles and, go have breakfast? But I think for me, in our society, a fancy coffee or a really nice leather seat on the airplane, or I think we're substituting joy for things that we've forgotten, and I was talking about this with Leslie earlier before I flew down here was that, you know, there's an element of we grow the most when we're struggling the most. You know, nobody reaches new barriers of joy when they're just in a good frame of mind, you know, watching a baseball game. Go Cubs. But they, you know, I've learned more and I've grown more in my darkest, hardest moments than ever before. Is that a little bit like running a really long race? Yes, you have to keep going. But yeah, joy. It was missing for decades in my life.
So I want to ask Todd a question, because you have talked about that a lot and how much you've learned and grown from your illness. With that in mind, I'm taking this question from a TED Talk that I saw with Ellen Sachs, who is a person with schizophrenia who wrote several books and was the chair of the University of Southern California Law School for many years. And she was asked the question, if you could alternate, if you could go back in time and change things, would you rather not have schizophrenia? She quoted writings of another famous person saying, if you take away my demons, my angels may flee too. But she said for herself, because it was so challenging, she would. So I wanted to pose that question to you.
Yes and no. And yes, because of all the devastation it's caused people in my life and myself, because I've really hurt a lot of people really badly. My children, my wife, everybody. No, because I guess if we didn't have Helen Keller, would we have Braille? You know, and sign language. And if we didn't have Abraham Lincoln, who, if you know his story, grew up with an abusive father, had to sneak away and steal books from the library because his dad wanted him to just work in the fields, would we still have slavery? So would I be sitting here helping you understand what I've gone through? No, I wouldn't be. And so, you know, yes and no. It's caused a lot of devastation, but it's given a lot of education and understanding and hope and healing too.
So I want to end with both of you giving some insight into things you've referenced, and starting with you, Todd. You mentioned and gave several illustrations of people being involved in your model. Mm-hmm. Can you give us a little more insight into what exactly, and I know I'm giving you like 120 seconds here, but just some insight into what does it look like to participate in the model?
Basically, the participants I had in the model were people that I worked with or children. Actually, two of them were children of people that I worked with. I used my experience with them as almost like you would if you had a hypothesis to, you know, put people through that program, that treatment, to see if it fit, you know, and I needed to change anything. Like I say in the model, this is not, you know, this is a first step of a dialogue that is most likely going to change. But if you are interested in that, should you get my email now? It's Todd Crush, which is my name, CRUSH 2222 @gmail.com. Reach out to me. You can also reach out to me on Facebook. That's a little tricky because if we're not friends, it goes to some random folder if you have a business page, but email is probably the best. And I am always looking for ways to help, from professionals to participants to whoever, to see how we can take the model from what I've put forth and change it and alter it with lived experience, clinical experience, all of it. I think, you know, not just the model, but all of this is a big step towards educating officers and doctors and everyone.
Beautiful. Todd Crush, 2222 @gmail.com. So Amy, I know you mentioned interventions, you know, and I'm, again, out of curiosity, is that like a one-time thing? Is that ongoing? Give us a little more insight into that.
So for about 10 years, we ran it consistently, and we ran forms of it that I think would be very productive to have in clinics where in multifamily groups, and they were ongoing to the degree that you could come for a year and go out and be functioning fine and then come back. Ideally, we need to have more of that in actual communities. So we're not running this intervention. It is out there. If you want the intervention, contact me, because there are now many therapists that are trained, that are practicing around the country, and so I can probably find you the person who can give you this intervention, and I can give you resources that we have for all of the families that come through the clinic for after. So I have good resource lists at easily accessible, and so please reach out, and I can give my email now. It's my first name, Amy, and then wiseman@miami.edu, and I have a few business cards if you want it with the email.
EI. Right?
Did I spell my own name wrong?
Well, you didn't spell it.
Oh, thank you. Yeah.
So, we've had a full morning. It's very helpful. Thank the two of you for the work you do, the passion that you have for it, and the willingness to share it. Because as I told Amy when we were waiting for this portion, the opportunity that I hope we can continue to do, whether it's collectively through Samaritan or whatever, is to continue to bring conversation forward that maybe people haven't heard before, or that we know they need to hear, and let's give a platform to it. So thank you for being willing to do that and doing that for us today.
Thank you.
I wanna have everybody thank John and Samaritan, because John's been the driving force for all this for almost a year.
All right, well, that is our time today. And for those of you watching online in Miami, Arkansas, wherever you're watching from, thank you for joining us today. A reminder that if you are looking for CEUs, to send me an email so I can send you a link to an online form to do that, and that's john@samaritangulfcoast.com. Reminder, those in your room looking for those, make sure and leave your forms with us if you have yet to leave that. You can just leave it on the table out there, or hand it to one of us on the Samaritan staff back at our table as well. Nicole's back there if you want to leave it there. I do have a request, and it's not an obligation, it's just a request. I'd love to get a picture of everyone in the room up here by the stage. So before you leave, if we can do that, and Nicole, I'm going to put you on the spot. Nicole's going to be our photographer. I just think it'd be great to have a photo of everybody, and I'll ask you two to go down and be on the floor, and we'll just all surround you, and this will be our exit, our dismissal for today. So come on down.